There are several significant changes in 2022 ESC guideline when compared with the previous one published in 2014. First, the self-reported inability to climb 2 flights of stairs by the patient in order to easily and rapidly assess functional capacity has regained attention and should now be considered in patients referred for intermediate to high-risk surgery, and this is a Class 2A recommendation. Second, in patients aged over 70 years and scheduled for intermediate to high-risk surgery, frailty screening should also be considered using a validated screening tool at the frailty index or the clinical frailty scale, for instance. And this is also a Class 2A recommendation. Third, whereas both pre- and post-operative use of cardiac biomarkers, namely troponin and BNP, were weakly recommended in 2014, it was a Class 2B recommendation, they are now strongly recommended before intermediate and high-risk surgery, becoming a Class 1 recommendation for troponin and a Class 2A for BNP. And fourth, resting transthoracic echocardiography is now widely recommended from Class 1 to Class 2B, depending, of course, of the patient's profile, before intermediate to high-risk surgery, despite lack of evidence that it reduces post-operative major adverse cardiac events and mortality. Those modifications, and especially the increasing use of echo, preoperative echo, and assays of cardiac biomarkers have the potential for huge modifications of care providers' practices and organization. The new ESC recommendations have been endorsed in extenso by the ESAIC, so that we must consider revisiting our practices and find a way to implement them on a daily basis. In order to assess their applicability and measure the potential gap between them and routine practice in our tertiary center, we performed a one-day retrospective single-center cohort study, including all adult patients scheduled for a non-cardiac surgical procedure at the exclusion of obstetric. 250 patients were included and analyzed. Among them, 72% had cardiovascular risk factors, and 34%, roughly 1/3 of patients, a known cardiovascular disease. If we only focus on the use of cardiac biomarkers and resting pre-operative echo, which are the most challenging new recommendations. Transthoracic echo was theoretically recommended for 17% of patients in our study, that is 43 among 250, and the performed unrecommended ratio was only 0.21. That is 9 patients among 43. And regarding cardiac biomarkers, they were globally recommended for 24% of patients, that is a quarter, 61 among 250, and the performed unrecommended ratio was simply 0, 0 patients received preoperative echo on 61. Thus, we found a dramatic gap between the most recent guideline and routine practice at the moment. What are the perspectives? 2 perspectives. First, the proportion of patients needing preoperative echo represents in our study nearly 1/3 of the daily total echo throughput in our echo lab, suggesting both a reorganization of the echo lab and focused cardiac ultrasound exams performed by trained specialists other than cardiologists, for instance, anesthesiologists. Second, regarding the liberal use of cardiac biomarkers, some differences in the methodological approach, also taking into account practical and clinical aspects of perioperative cardiac risk assessment, could lead to potentially different recommendations as very recently suggested in the ESAIC focus guideline for the use of cardiac biomarkers in perioperative risk evaluation.